Good evening. Without much delay, we should commence our today's class, that is about hematological management of EDIC Part 1, which would be conducted by Dr. Judhajit Sengupta. He is a consultant in critical care medicine at NH-RTIICS Tagore International Institute of Cardiac Sciences. His area of interest is in pulmocritical care and ECMO. Over to you, sir.
Good afternoon, everyone. Today's class is on hematological management. It should be an interactive class. How many of you are critical care students and appearing for EDIC Part 1? I guess everyone is appearing for EDIC Part 1, but how many of you are critical care students?
Appearing for EDIC Part 1, sir.
You are working in which hospital?
Sorry, sir?
You are working in India?
Yeah, sir. I'm working in India, sir. In Hyderabad.
Okay, your IDC, you are pursuing IDCCM or TRNP?
Sir, I just finished my FCCM, sir.
Okay. So all of you have undergone some sort of training, I guess, and everyone have read the basic things in critical care, right?
Yes, sir.
I guess so. Anyways, regarding the EDIC Part 1 preparation for him, then I should not waste any time on covering the basic things in hematology. All of you know, hematology has few areas like one part is anemia. I think everyone knows everything about anemia. One part is thrombocytopenia. I think our main focus should be this thrombocytopenia, bleeding, and TIC and other related complications, right? Because most of the questions in EDIC Part 1 comes from these areas. So different parts of hematology are anemia, thrombocytopenia, maybe bicytopenia and pancytopenia, disorders of coagulation, bleeding, and TIC or other related issues in critical care medicine in ITU. I would go very specifically about the areas which are most important for examination and which you are supposed to cover for expecting a question. So firstly, what is thrombocytopenia? Everyone knows the definition of thrombocytopenia. It is a very common phenomenon in critical care, and usually a case is given where the patient is having thrombocytopenia. A few blood coagulation tests are given, some parameters are given, and you are asked about the diagnosis or management of that patient. So I guess everyone have gone through the normal coagulation cascade. I guess so. So only 2-3 things are important regarding that. Always remember that there are 3 areas which you need to remember separately: that intrinsic pathway, extrinsic pathway, and common pathway. Calcium is very important cofactor. Deficiency of calcium may cause coagulation abnormalities. And regarding the coagulation tests, like PT, INR, APTT, thrombin time, activated clotting time, and fibrinogen level, fibrinogen degradation product, T-dimer, and thromboelastography. These are the coagulation tests everyone needs to know. Now, regarding the prothrombin time and INR, actually it represents the extrinsic pathway and common pathway, and it is prolonged when there is some sort of abnormality in the tissue factor or factor 7. Isolated PT prolongation occurs in case of warfarin therapy, vitamin K deficiency, severe liver failure, or deficiencies of extrinsic pathway factors, or deficiencies of the common pathway factors like factor 10, factor 5, prothrombin, fibrinogen, and also in APLA. So there might be some MCQs where you need to know the differential diagnosis of isolated prolongation of PT. And PT INR are almost same. Actually, it depends on the tissue factor. So this is INR is the basically ratio of control and patient's tissue patient's PT. On the other hand, APTT represents actually the intrinsic and common pathway, and the APTT gets prolonged in heparin therapy, hemophilia A, B, and C, and in APLA, and also in the von Willebrand disease.
Your PowerPoint is not visible, sir.
Actually, I just written the points in the PowerPoint. If you want some detailed, I'll send you afterwards. Okay.
No, sir. If you are it's like if you're showing your PowerPoint, it isn't visible over here. We thought that you are just verbally communicating. So
I'm
you
just
sharing
verbally
your screen.
communicating.
Okay,
I'm just verbally communicating. I have prepared a basic PowerPoint. If you want any details, I'll of course prepare it and will share it with the students. Okay.
Okay, so sure.
Now, next comes the fibrinogen level, which is important for the formation of fibrinogen mesh, and usually it is deficient in case of massive bleeding or in case of DIC. Now comes the thrombin time, which is usually prolonged in case of heparin therapy or in the presence of thrombin inhibitors like hirudin, argatroban, tanaparoid, etc. And also gets prolonged in hypofibrinogenemia. Fibrinogen degradation product and D-dimers are other things which are also measured. These are usually elevated in case of DIC and other incidences where there is systemic activation of coagulation pathway occurs. Now, activated clotting time, it is usually used to monitor anticoagulation during CABG or during utilization of the extracorporeal circuits. And usually the goal of ACT is 160 to 220 in case of extracorporeal circuit or ECMO. And normally it is the 4 times of the pre-heparin ACT. So this is what we need to know regarding the coagulation tests. So our next topic would be thrombocytopenia in ICU. And just forgot to mention that TAG and rotem, these two are extremely important, mostly for EDIC 2, also for EDIC 1. These thromboelastography or thromboelastograms are being used increasingly in the ITUs of Europe. So they are fond of asking these questions. You need to go through the pictures of this TAG and rotem, and you need to know the interpretation of this thromboelastograms. And I think we need a separate class where we can discuss this this TAG and rotem interpretation. Next comes thrombocytopenia. Thrombocytopenia is very common in ITU, and whenever we get a patient with thrombocytopenia, first we need to exclude whether it is a true thrombocytopenia or false thrombocytopenia. In case of platelet clumping or in case of giant platelets, the results may be falsely low. And so even when it is a true thrombocytopenia, then it is probably an acquired, there must be some, this must be acquired thrombocytopenia. If it is isolated thrombocytopenia, then the probable diseases are ITP, drug-induced ITP, HIV, HCV, or DIC. But if it comes in association, if you send for a peripheral blood smear, if there is associated blast or nucleated RBC, that that means there might be some intrinsic bone marrow disorder.